Hey guys, so I have a patient that's come in with an injury, so basically a low back pain due to a disc bulge. So here's a history of the patient. So patients experienced a minor disc bulge L5S1 following an accident in 2022, which led to the sciatica. Through consistent exercise physiotherapy, they've been able to relieve approximately 90% of the pain and significantly ease the sciatica. Uh, but what's happened since is that they continue to experience intermittent pain or discomfort, primarily in the left SI joint area, with occasional extension to the tailbone and down at times down in the outer leg. Patient reports a sensation of a slight bulge in the region, with discomfort has been getting worse and worse in the last 7 to 8 months. So this is important. So basically, the minor disc bulge L5S1, there's a good chance it has already healed. But as a result of this accident, there is ongoing issues that are occurring down the stream, meaning down into the muscles themselves, particularly, that were probably not addressed by the previous physiotherapist. And also, what usually tends to happen is that when patients do get these diagnoses, disc bulge, they right away is always trying to connect their pain to that original injury in some way, even though a lot of the times it does not necessarily cause that pain. And that's one of the dangers of specifically diagnosing patients with specific things, is that their brain, as a result of that diagnosis, now tries to justify all the pain as a result of that one particular issue that has occurred, which could or could not be the case. But more often than not, it's not the case. So that's why what we do here at Pain Free Health is we try to focus on the muscles individually rather than worry a ton about these diagnoses, which can be, they sound very dangerous to patients, and it's something that, it's obviously good for them to know, but also it's good for them to be educated on the fact that their body's stronger and is able to adapt a lot better than they think it will. So certain activities that exacerbate the pain, standing work increases discomfort, and you'll see why. Sitting job further aggravates the symptoms, and I also potentially have a theory as to why. And some exercise seem to worsen the pain. Once again, you'll see why when you see the single leg standing picture. So here's the single leg stance. So you can see on the right side, he's got a little bit of a ladder shift, but it's pretty good overall. Center of mass is a little bit on the outside. I would kind of like it going straight down the heel, and then you have a good weight distribution and good center of mass distribution. But overall, it's not bad. Now let's look at the left side. So one of the things that right away jumps at me is the rotation in the upper body. So this gives you a good indication as to what's happening. Why is this patient rotating in the upper body? So this is most likely a compensation. So you can see I even did a little arrow here, a clockwise rotation on the left side. The reason why that's happening is potentially because of the fact that this hip muscles, this hip stabilizers, the core muscles of the hip are not able to stabilize the whole body as well. So as a result of that, what's happening is this patient's rotating, and they're using more of their hip flexors, and they're also using more of their ligaments to stabilize, such as the IT band, the tendons to stabilize the hip when they're single leg stance. And that's why I like the single leg stance. It gives me a good idea as to what's happening. Also, we notice a Trendelenburg, so meaning that this hip is dropped. Guess what happens? This hip is shifting out laterally, and also the center of mass is is quite a bit outside, and that's an issue as well. So as you can see, this type of a posture, especially when the patient's standing or walking, will cause more discomfort. Now, you'd ask yourself, why is the sitting more of a discomfort? Well, the reason why sitting can be more of a discomfort is, if you think about it, when the patient's sitting, guess which muscles they're using a lot more? It's the hip flexors. So as a result of that, those hip flexors are already overused and they're contracted. And being in that still contracted state causes more inflammation. So what we got to do is work on work on reducing these issues, and that's kind of going to be the next game plan. But it's before you even start with the assessment, I highly suggest just getting, especially if they're dealing with hip and low back issues, get them to stand on each leg. Like I say, it's ideal if you can take a picture, because of the fact that then you can go back and really get an idea as to what's going on and compare the two sides. So basically now we're going to go into the objective. The range of motion, the range of motion is within known limits. There's no issues. When we did look at the strength, this is in sideline. Left hip, quite a bit weaker than the right hip. And that's something that we have expected already based on the stance. Special test, straight leg raise is within normal limits. So that rules out that sciatica pain. So this L5S1 issue is going to be, still potentially does play a bit of a role, because every time you compress the nerves that are feeding the muscles in this area, so every time the nerves are compressed, they're irritated as they're coming out and supplying the muscles aren't going to be happy. So it still can play a role, but that straight leg raise being within normal limits means that sciatic nerve is not all that irritated, which indicates that this probably this issue that's happening on this left side could also be from the trauma, the accident that has occurred as well. We've noted some major trigger points: left gluteus medius, gluteus minimus, and that's probably one of the reasons why they're not working, is because they have those trigger points. The TFL trigger points probably because it's being overused, and we also see some trigger points in tibialis anterior and peroneals, as well as the groin muscle. So I'll touch base as to why the groin muscle. So the tibialis anterior and peroneals is an interesting one, because a lot of times people with that sciatica disc bulge pain also say, hey, I got numbness and tingling into my foot. Although it can be coming from that nerve, one of the good ways to basically also see whether that numbness is also coming from these two muscles. It's very simple. All you got to do is press on those muscles to see how those trigger points are behaving, because a lot of times these are the guys that can also cause that numbness and tingling. And if you can release those muscles, see whether that helps, can potentially be a game changer. Because like I say, a lot of that numbness and tingling doesn't necessarily mean that it's the nerve, but it's also can be coming from these muscles. And the reason why these muscles get overused, once again, is because gluteus minimus and all the glute stabilizers, they're not functioning. So they're not functioning, meaning that this hip shifting out laterally, what's going to be used is your peroneals as well as your tibialis anterior at the front. So they're going to be overused, if anything. And also, as you can see, as soon as this hip drops like so, what's going to happen is that these groin muscles, they're going to contract, meaning because the groin muscles come from here, they go all the way into the pubis bone. As a result of that, they're going to contract and stay in that contracted state to stabilize this hip, because the hip muscles aren't firing. So as a result of that, you're going to potentially find some trigger points in the groin as well. So based on this picture, you can kind of already guess and have an idea which muscles are happy and which ones aren't, and what's going on. And also, because the fact that the groin muscles are contracted, that can also impact the SI joint pain as well. So looking at not only just the SI joint, but also the guys at the front and what's going on. And also, one of the reasons why this patient may experience that tailbone and SI joint pain is because of the fact that every time he stands on this left leg, this hip is dropping down. What that's causing is a lot of movement and a lot of shear in that SI joint area, which could further be causing the flare up in that area. So basically, this is objective. My first treatment is I touched base on all of these areas. I even went up into the rotator cuff and the neck. Which, I mean, first session, you don't necessarily need to do that. What I would do is focus on the hips, definitely, especially the left hip, left groin, lumbar erectors you can look at, and also the hamstring, because the hamstring can also get contracted and stay irritated, especially if there was some sciatica there at some point. Treatment, And also I would definitely look at point release to TFL and ITB. And then I also did some IMS with this patient. You could also do some shockwave. So plan-wise, short-term, what you want to do is get that patient out of pain as much as you possibly can. So add some foam rolling or release work to the left groin. Add some of that to the ITB, TFL. Some hip flexor stretches would be beneficial as well as some ball work around that left SI joint, releasing wise. But the thing is, you have to realize all this releasing and all that stuff can only go so far if that patient's continually doing this motion. So long term, what we need to do is long-term plan. What needs to happen is we need to work on strengthening of left hip. So rather than strengthening, stability. Stability is key, because you can work all day long on the strengthening, but also looking at how this patient will behave on single leg stance. That is the key. So retesting this, what I would do is start them on some non-weight bearing exercises and then progress to weight bearing exercises, but making sure that they're easy enough so that this patient's able to engage these glute muscles. So controlled single leg stance exercises, and then you get into more complex things. And when I do talk to patients, this is probably a 6 to 9 month plan that we kind of develop. And they don't need to see me every single week. If they can see me every 3 weeks, every 2 weeks, for this type of stuff. And for me, every time they come in for me to kind of look and see how the hip is doing, and how that stability is in the hip. That's the great long-term plan. So short-term, get the patient out of pain. Long-term, look to see how we can improve the biomechanics so that the pain overall gets better, and we get him using the muscles such as the glute muscles here and also the vastus medialis to work together to stabilize the femur.